Okay, next I would like to invite Dr. Swapna Nair. She will be speaking about intracorneal ring segments, when to do in keratoconus and when to combine with simultaneous or sequential CXL.
So we'll just go into the role of intracorneal ring segments with or without CXL in keratoconus. Now what we are trying to assess here is when it should be implanted, would it be done in conjunction with CXL, and what to expect following such situation. So this all started when 360-degree rings were implanted for myopia, and first it was done for keratoconus in 2000 by Collin. So what we need to remember is the diameter of the ring is inversely proportional to the dioptric correction required and the thickness directly proportional. And we do it in the posterior stroma because it is less compact. So now the mechanism of action of CXL is that it strengthens the cornea and takes care of the pathology. The rings actually make the curvatures of the cornea better and decrease the higher order aberrations. So the depth of placement also decides on what kind of stress, resultant stress happens in the cornea. So if it's the posterior stroma, that's nearly 80% of the depth, then there is prevention of ectasia progression. So anteriorly, there is actually increment of stress. So that is where the depth is important. Now the mechanism of action, the favorable ones are space creation between the corneal lamellae. There's shortening of the arc length, so it's that's why Dr. Rajesh talked about a negative meniscus and a larger diameter organic cornea to be placed for additive therapy as well, because it shortens the central arc and flattens the cornea. There's change of the disease course because of this flattening and the subsequent response of the cornea, and a decrease of the higher order comma aberrations that are commonly seen in keratoconus. Now all these are the indications of which I'll basically be talking about keratoconus. In keratoconus, now what are the indications that may let us use an ICRS? So the K value should be more than 46 diopters. You need a central, clear and non-scarred cornea with a corrected distance visual acuity of less than 6/9 parts and loss of lines due to keratoconus. The corneal pachymetry at the site of implantation of the ring should not be less than 400 microns, 450 microns for safety's sake. And then the alignment of the refractive and keratometric axis between 0 and 15 is considered to be proper, and those cases respond best. Now contraindications, like I mentioned earlier, scars dystrophies and pregnancy, erosions, drug intake. Should be cautious in large pupils, eye rubbing and low endothelial cell counts for obvious reasons. So these are the types of ring segments that are available: the Intacs from Addition Technology, the Ferrara rings, the Kera rings, Mayo ring. So I'll be discussing basically Kera rings and Intacs because these are the ones that are commonly used. So now this is how a Ferrara ring is inserted using a keratome. So this is a mechanical form of insertion which is rarely done now. So now this is actually a very complicated technique, and it involves using this particular type of keratome that creates the pocket in a circular fashion. So with the femtosecond laser, this is actually not required. So what we do now, now this is another instance of Mayo ring insertion. So you can see it's a total 360-degree ring, and
the
if you have
pocket was
a lot
created
of
before
central
with the
steepening,
pocket maker
then it helps in
microkeratome at 300
reducing
microns depth.
steepness
The diameter
of
of the
cornea.
pocket is
because
9 millimeters.
when you're talking of Intacs, you're talking about arcs. Now femtosecond, can you give me a whole screen for my video here so that I can forward it if I want to? Yeah, so for femto Intacs, basically you create two pockets on either sides and an incision at the center. So that is the application. You can see that the incision happens very fast in just a couple of milliseconds following the application, And then this incision, the stromal pockets, they need to be incised a bit at the beginning, followed by passage of the rings. So here you can see that the incision with a central large pocket is there. That is where you make the first incisions to pass this instrument there. So this will expand the incision and give a leading a pocket for the leading edge of the ring to be passed. So now you also have asymmetric rings, you know, with different thicknesses at different end and different diameters and different kind of shapes at different ends. So such asymmetric rings are also available that produce separate kind of flattening in one pole compared to the other. So once the rings are passed inside, they are tugged neatly, and then this central pocket is sutured. So that was the basic method of doing the procedure. Now there are different types of cones that we can deal with. So if you have a central myopic cone, then symmetric segments may be preferred, or a 360-degree myo-ring kind of a segment may be preferred. If you have a high amount of astigmatism or a snowman kind of configuration, then you can have one on either sides. They can be symmetric or asymmetric depending on the type of cone's symmetry. If you have highly oval cones, or which are more confined to one quadrant or one side of the cornea, then you can go in for single inferior segments. So the mid-peripheral pachy is not very important in such situations. You can see that this is less than 400 over here, but still you can implant a ring because the peripheral pachy is more than the area where the ring needs to be implanted is more than 500. Now the outcomes are excellent actually, because there is a huge change in the keratometric values, and the visual acuity improves drastically. The sphere reduces drastically. So these are the anterior segment OCT pictures. Now when you want more corneal flattening, you need symmetrical implantation with greater ring thicknesses, narrow channels, and more astigmatism reduction when you have incisions on the steepest meridian and you insert the rings on the flattest ones. So these are the various combinations that you can use with intacs. And we have always found, there are multiple studies, this is one of the latest ones which highlights the benefits of CXL along with ICRS, and they have found a significant increase in visual acuity, decrease in steep K, and decrease of the mean cylinder value in these eyes. And so the benefit mechanism is that there is a traction effect of the ring at the end points on the astigmatic axis along with strengthening of the cornea. Now the question is, which comes first? So again, there are multiple studies. Now this is one of the earlier ones which found no difference whether you're doing CXL first or whether you're doing ICRS first. But then later studies have slowly proven, this is one of the later ones which had proven that CXL after ICR's implantation, not very late, but maybe along with it, is a much better technique. So now this is the total, this is I think the most important slide in this presentation, which is the total, sum total of all the studies that have been conducted, combining, I'll just take half a minute. ICRS and CXL performed simultaneously or sequentially has a synergistic benefit. And if it is performed before ICRS, it stiffens the cornea and makes the pocket creation a bit harder, so that you cannot pass the rings as easily as you would otherwise. On the other hand, if you do a ring implantation and clear the central cornea and do an accelerated CXL in the same sitting, it provides much better benefits and much safer treatment also. So this is the summary of what I presented before. Then of course you have some of the complications which are actually less than 5%. One of the important ones being extrusion of the ring epithelial ingrowth, and rarely penetration of the anterior chamber. The studies which talked about these, there can be some innocuous white deposits at the Kera ring, terminals, which are basically fatty acids. Ring extrusion is a problem, but even that is less than 5%, especially if it's implanted at the proper depth. It needs to be removed in such cases. Neovascularization may happen, especially for larger diameter rings. So this is what the histopathology of the cornea shows. There are inflammatory cells at the site of ring implantation, attenuated corneal endothelial cells, hypocellular collagen scar at the inner edge, and macrophages. So basically there's some sort of an inflammatory reaction, little bit of compromise of endothelial. Now the longest follow-up was for 68 eyes, that was in 24, and it has shown that it gives very good results, but sometimes over a large period of 10 years, the results may taper off. Thank you very much.
Thank you, Dr. Swapna. It was a very nice coverage of the topic. Can I request Dr. Anand to please come up, and meanwhile we can have any question for Dr. Swapna? Yeah.
I haven't. Yeah. Because
Because there were two index and they started touching each other, and then it loses the effect if it touches the other. So I went to manipulate. Unfortunately, the proper instrument was not there. There was a little tilt in the index. I'm talking about the older time that we used to get those hexagonal segments. So that sharp segment it eroded inferiorly because of thin cornea and over a period of time. So I had to actually move that and we put a leveler patch graft with the would work with.
We had one case referred by someone who had infection, developed very severe infection. So in that case, we had to remove it, and first we, the track was drained and with antibiotic and all that. But the infection was quite severe. It progressed, and finally we had to do a therapeutic graft. So that is something, I mean, rare. That is extremely rare. But yes, that can happen rarely, very rarely.
I think it's a femtosecond laser that is the greatest advantage, because you can accurately calculate the depth and there's no penetration or extrusion.
Just a couple of points to Sapna's lovely presentation. I think one is, I think the depth is probably the most critical part. If you're, rather than calculating from the anterior, I calculate from the posterior. So if you have 20% behind, about 120 microns behind the intact is probably more important. And the second part was in terms of follow-up. I feel if you manage the allergy aggressively with traclomas and topical cyclosporin, you just have to tell them to avoid. Any experience with the allergenic implants?
cares.
Yeah. Anybody? Rajesh?
No, I haven't done it.
Yeah, no, we have done about 4, so I have a 2-year follow-up, but I find that, and I've seen patients from other hospitals who have come to me for follow-up. I think the challenge is the predictability. I feel that nomogram, because it's a soft tissue, you don't know how much is going to correct, and the thickness is quite standard. So I think it's still in evolution.
Time, I'm sure it shrinks.
It's still.
Yeah.